Good morning. I will call the Committee on Health and Human Services to order. It's Wednesday, February 15th, 2023. We have two bills on the agenda today, and we have a presentation from the Department of Health, and there is a quorum present. Our first bill on the agenda is Senate File 705, which is Senator Morrison's bill relating to the Minnesota Rare Disease Advisory Council. And welcome to testifiers. And Senator Morrison, please proceed.
Thank you, Madam Chair. Madam Chair and members, thanks for the opportunity to present Senate File 705, which would provide funding for the Minnesota Rare Disease Advisory Council. The Rare Disease Advisory Council's creation is a recognition of the rare disease community as a distinct subset of the healthcare population with its own unique set of barriers and challenges. There are more than 7,000 different rare diseases identified, and when considered collectively, they affect 1 in 10 people in the population. The council was established as an executive branch state agency in July of 2022, but it does not have a base budget as it was only appropriated funds through fiscal year 23. So Senate File 705 establishes the necessary funding for the council to function well. But I will turn it over to the council's executive director, Erica Barnes, to elaborate. Thank you.
Thank you, and welcome to the committee. Ms. Barnes, please state your name for the record and proceed with your testimony. Thank you.
Thank you, Chair Wicklund. My name is Erica Barnes, and I'm the Executive Director of the Minnesota Rare Disease Advisory Council. Thank you for allowing me to speak today on behalf of the rare disease community and the Rare Disease Advisory Council. As Senator Morrison said, when people hear the term rare disease, they often assume that that disease affects only a small portion of society. And while this is true if each rare disease population is considered individually, when the over 7,000 different rare diseases are considered collectively, they affect 1 in 10 of the population. Individuals can be affected in a myriad of ways by their rare diseases. They may be born with skin so thin, like my friend and University of Minnesota student Mohammed, that they are referred to as butterfly children and live in constant pain. Or they may, like Rare Disease Advisory Council member Ray Blaylark's son, have a disease that affects the biochemistry of their sickle cells that can lead to organ damage, swelling, stroke, and again, chronic pain. Still others, like my daughter Chloe, may be born apparently happy and healthy, but eventually lose the ability to walk, talk, swallow, and breathe on their own. In spite of these varying symptoms, there is one thing that nearly all individuals with rare diseases have in common: a strikingly similar set of barriers above those encountered if diagnosed with a more common disease when seeking to access care in our healthcare system. These barriers include extreme delay in diagnosis. The average time to diagnosis for a rare disease patient is 7 to 8 years. Difficulty in identifying a clinician with expertise to treat the individual's rare disease. This can require relocation to a new city or state, and significant disparities in treatment options. You see, only 5% of the 7,000 rare disease patient populations have an FDA-approved treatment at this time. It was the recognition of the lack of equitable care for the rare disease patient population that motivated a 42-member coalition to call for the creation of the Rare Disease Advisory Council in 2019. And thank you to those of you who voted for the creation of the council in 2019. The council's vision statement is this: we envision a world where every Minnesota citizen living with a rare disease has access to a timely diagnosis, comprehensive care, and an effective treatment. As you can see, our mission statement is driven by the needs of the community. In a moment, one of our council members will tell you a bit about the work that the council has engaged in and his own work. And because I know that Dr. Orchard isn't going to tell you this, Dr. Orchard is world-renowned for his work in the rare disease space. The work he is doing in the space of gene therapy is first in the US, first in the nation. Some of the work he's doing was work that Children's Hospital in Philadelphia, Boston Children's, the researchers there wanted to do, but he brought the research here to Minnesota, so we should be very proud of Dr. Orchard. In closing, I want to leave you with this quote from Abby Myers, founder of the National Organization for Rare Disorders and mother of a son with a rare disease. Families affected by rare diseases represent a medically disenfranchised population that falls through the cracks of every healthcare system in the world. By funding this council, we can ensure that no one is an afterthought in our healthcare system, no matter how rare their diagnosis. Thank you.
Thank you for your testimony. Dr. Orchard, welcome to the committee, and please state your name for the record and begin your testimony.
Thanks very much, Senator Wickland. My name is Paul Orchard. I appreciate the opportunity to be here today to testify in support of the Bill SF 705, providing ongoing funding for the Rare Disease Advisory Council. I'm a pediatrician specializing in bone marrow transplantation at the University of Minnesota. My practice is primarily focused on the treatment of patients with rare inherited life-threatening diseases that are amenable to bone marrow transplant. And more recently, we've been quite interested in gene therapy, as Erica alluded to. We were the first institution to be able to offer gene therapy for metachromatic leukodystrophy in the country. We've treated now 3 patients, and we remain the only place that can offer this therapy. I've had a great many families in my practice that struggled with a difficult and extended journey to obtain a diagnosis for their sick child. Following this, families routinely spend a lot of time searching to find information about the disease, who the experts are, what therapies may be available, and how they might be accessed. They may turn to the primary physician, but it's a great deal to ask for any physician to be familiar with even a small proportion of these rare conditions. Some of these, like cystic fibrosis, are extremely well known. Others, like adrenoleukodystrophy and Hurler syndrome, are not. There are approximately 4 million babies born a year in the United States, and Hurler syndrome is, for instance, 1 in 100,000 births. There's only approximately 40 kids born in the U.S. yearly with a diagnosis like Hurler syndrome. However, in the last few months, there was a baby picked up in central Minnesota by newborn screening that has Hurler, and is being considered for transplant. And I had the opportunity to help counsel that family about therapy for their little girl. She's going to be admitted for transplant in the next few days. 2 years ago, the National Organization of Rare Disorders designated 31 centers of excellence throughout the country. Minnesota is privileged to have 2 of these centers, the Mayo Clinic and the University of Minnesota. Minnesota has a long tradition of national and international leadership in the field of rare disease, but there's much yet to do. During the Council's first 3.5 years, we focused on getting better understanding of the challenges to the families in terms of obtaining a diagnosis, the financial burden that they're forced to undergo, and ultimately how we can improve their quality of life. We're ready to implement new solutions. In summary, I believe there's tremendous opportunity and potential inherent potential inherent use in the Council. It's been my privilege to play a small role in it. I hope you will support the requested funding so that we can continue the important work. Thanks very much.
Thank you very much for sharing the information and the valuable work you're doing, both of you. I really appreciate hearing about the council and the work. Members, do you have any other testifiers? Or those are the only 2?
Madam Chair, these are the star testifiers.
Yes, they are. Members, do you have any questions for Senator Morrison or the testifiers? Not. Oh, Senator Atke.
Thank you, Madam Chair, and thank you to the testifiers for what you do. I'm just trying to find out a little bit more. What does the council do? I realize, is that kind of what brings everybody together, or does the council actually participate in some of this, helping, whether it's get providers? I'm just trying to understand where the council comes into this, because I mean, we've got a very talented doctor in front of us, and just wondering about the council, just to help out there.
Ms. Barnes, would you like to answer that?
Senator Wickland, Senator Utke, yes. So some of the stated duties in our legislation is to provide advice and information both to the medical community and to provide resources to the medical community, as well as to provide advice to some of the agencies of the state. We've done a number of things in terms of the advice that we provide. We're engaging with the Newborn Screening Committee talking about, so one of our goals is to reduce the delay in diagnosis. So we focused on working with that committee to find ways to do that. We've also collaborated with a couple of other different state agencies. In addition to that, the council has a number of work groups, and right now, our main focus is to develop some support tools for the medical community. So I always say that we don't want to start asking doctors to do more. We want to ask them to think differently. So we have a number of projects. We collaborated with the Minnesota Medical Association to design a telementoring program. It's called Project Echo. Very, very excited about that. So we're right now in the middle of collaborating with the Minnesota Medical Association, and that telementoring is organized around the transition of care for individuals with rare diseases. So when a patient moves from pediatrics to adult care, that transition from those two systems can be incredibly traumatizing and difficult. We actually see a spike in mortality rates for some of our communities when they try to transition from pediatric care to adult care. So we're really focusing on providing support tools for physicians in that way. I've also worked with a PhD student at the University of Minnesota in the bioinformatics department, and we're working on some data tools to implement or to use technology better to identify these patients. Did that give you an answer?
Senator Etke?
Thank you, Madam Chair. Yes, that's kind of what I was looking for, is all the different things you're involved with as a council. So thank you. One last question I have. We have money appropriated for this biennium and the next. So at this point, it's an ongoing appropriation.
Senator Morrison, if you want to.
Madam Chair and Senator Utke, yes, that's right.
Okay, thank you.
Other members have questions? I guess, Ms. Barnes, maybe you could tell me a little bit more about how do you work with specifically kind of the medical community to help get information out to connect parents, or Dr. Orchard, if you would like to talk about that, to connect parents who might not otherwise realize there are people working on, the rare disease that maybe they're experiencing that process. If you could tell us a little bit more about how you do that work. Thank you.
Sure. Senator Weckland, thank you for that question. Yeah, so I'm prior to my role as executive director here, I ran a nonprofit in the patient advocacy space, so I'm very embedded in patient advocacy, and many of these parents have my number on speed dial. Same with Paul, I'm sure, for his patients. So some of the ways that we've worked to, and you're right, being able to connect those patients to the appropriate specialist is half the battle, right? So in addition to collecting the resources and trying to be a central repository in the state of Minnesota where families can connect with us, the council will be hosting, in conjunction with the University of Minnesota Center for Orphan Drug Research, we'll be hosting the Patient Advocacy Breakfast, and we're inviting all, we focus a lot on the patient advocacy communities more than individual patients, because those patient advocacy communities are connected to their individual patients, if you know what I mean. So we're hosting that breakfast, and we're going to present the work of the council, some of our policy goals, and get feedback from that community and do some listening sessions.
If I may, Erica.
Dr. Orchard?
So one of the things that it seemed as we formulated the council and got started is I think we realized we needed more information about some of these difficulties that the families face and the providers face as well. And so there was a series of surveys that were developed that went out to both the families and to providers to better understand what some of these barriers are. And I think that was important information that's going to help us move forward and better determine how we might serve the families in Minnesota.
Okay, thank you. And just one last question. As this is something that's going to be an ongoing entity, ongoing agency, and working with communities in an ongoing basis, can you tell me a little bit about how you how do you look forward in terms of, things you might not know about now, but anticipating either new, rare conditions that might fall into your into the area that you are working on. I guess, can you talk about how that work will go forward in future years? And I'm not sure if Dr. Orchard or Ms. Barnes.
Want to start?
Sure. Senator Wickland, thank you for that question. Yeah, I think one of the really salient features of the rare disease community is, that because the term rare disease is broad, we do anticipate that there will be more and more diagnoses. This space is very dynamic and with all of our genetic testing and all of the kind of sequencing that we're doing, we're learning more and more about rare diseases, and their numbers are increasing more and more for a number of reasons. And so, I anticipate that, and the council is very forward-facing in keeping a pulse on the advances in genetics going on and advances in the capabilities that we're learning for faster diagnosis, really exploring very deeply, and Dr. Orchard can speak to this a little bit more, to newborn screening and innovative ways we can do a better job at newborn screening for early detection. We have both a genetic counselor and a medical geneticist on our council, and they're actually the chairs and co-chairs of the council. So that's a big area that we want to make sure as a council we're being forward-facing.
Thank you. And Dr. Orchard, did you have additional comments?
Thanks, Senator Wickland. So the newborn screening piece is extremely important. I mean, for a number of these diseases that we care for, the best opportunity to make a difference in the lives of these patients and their families is to diagnose them early and intervene as early as we can. And newborn screening is really the best way to accomplish that. So we're very interested in moving potentials for newborn screening forward, working with the Minnesota Department of Health and other groups to help implement that, because to really make a difference in the lives of these families, we have to make a diagnosis as early as we can.
Well, thank you. Any other questions or comments? No. Not seeing any. Senator Morrison, did you have any final comments for us?
Thank you, Madam Chair and members, for considering this bill. As Director Barnes said so well, I think that rare diseases by themselves are rare, but collectively they're common. And I thought Dr. Orchard's comment that Minnesota has a proud tradition of leadership in this area makes this council all the more important. So I urge the committee's support. Thank you.
Thank you, and really appreciate your coming and testifying for us and bringing forward the need for the additional funding. At this point, we will lay the bill over, and then we will consider it as we move forward with our putting together the budget. So thank you again for your time.
Thank you, Madam Chair and members.
Good morning, Senator Kunesh. Thank you for joining us in committee today. And we have now Senate File Number 402, which is a Community Solutions for Healthy Child Development Grant Program bill. Senator Kunesh, do you have wish to begin your presentation?
Thank you, Madam Chair. Yes, I would like to share with you this morning our Senate file. Here we go. Senate File 402, and this is to establish Healthy Child Development Grant Program and continue the work that we have. I believe I do have an amendment.
And do you have a number on that?
It's the A2 amendment.
The A2 authors amendment will be distributed, so.
This amendment, the A2 amendment, deletes Governor's Early Learning Council and inserts State Advisory Council on Early Childhood Education and Care to reflect the current title of that committee. And then in order to keep congruent language, on page 4, line 7, delete age 3 and insert grade 3. And then on lines 26, delete 19 million and insert 50 million, and then again delete 20 million and insert 50 million. And that is my amendment.
Thank you. And this is an author's amendment. We have not, this bill has not been heard in any other committee, and so I would like to adopt the author's amendment. Let's see, Senator Kupek moves the A2 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Thank you, Senator Kunesh. Did you wish to proceed now with your bill?
Yes, thank you, Madam Chair. So thank you all very much for this opportunity to present Senate File 402. It's providing funding for the Community Solutions for Healthy Child Development Grant Program in the Minnesota Department of Health. The focus of the Community Solutions Program is to improve measures of well-being for children of color and American Indian children in Minnesota from prenatal to age 8 through this community and equity-centered approach across the state. Minnesota has some of the largest disparities between outcomes for white children and those for children of color. We are one of the very best states in the nation for child well-being and overall, but we look at children of color apart, we would rate in the bottom third of the state. Children of color are the poorest Minnesotans with vast racial disparities for our Black, American Indian, Latino, and Asian American children. In your handouts, you have a copy of the Kids Count Report, which provides extensive data on key indicators that I would ask you all to review. The Community Solutions Grant Program is a strategy by which we begin to address disparities in an upstream way. It leverages the assets in the community to address their problems. It brings those who are most impacted into the decision-making process. And I'm really proud to say that when the legislature created this pilot program called Community Solutions for Healthy Child Development in 2019, I was the author in the Minnesota House, and I'm very proud to come back and be able to advocate for it once again. The purpose of the Community Solutions Grant Program is to improve child development outcomes related to the well-being of children of color and American Indian children, prenatal to grade 3, and their families. That includes early learning, health and well-being, economic security, safe, stable, nurturing relationships, and our environment. It reduces racial disparities in children's health and development from prenatal to grade 3, and it promotes racial and geographic equity. The Community Solutions Program goal is to fund community-based solutions to address challenges that have been clearly identified by affected communities. The program seeks to fund strategies delivered by competent organizations that provide culturally efficient and relevant services to communities of color and indigenous communities. Eligible grantees include organizations, nonprofits, tribal nations that are either led or directly work with those communities of color and American Indian communities. And we really have to recognize that to help achieve equity, we must build authentic community partnerships and fund organizations that are led and trusted by the groups they seek to serve. In your folder, you have more information about the program and the list of organizations that have received those small grants, and you're going to hear from a number of them, of our grant recipients, and how effective these grants were. So I would like you to take a moment to look at those documents that you have there, and with that, I am ready to move on to any testifiers.
Thank you, Senator Kunesh. And would you like your first testifier to proceed? I have Brooke LaFleur. Welcome to the committee, and please state your name for the record and begin your testimony.
Thank you. Good morning, Senator Wickland and member of Health and Human Services Committee. My name is Brooke LaFleur, and I am the co-founder of Nenijanas One of Ones, a social enterprise for Indigenous children. I'm a citizen of the Turtle Mountain Band of Chippewa, a member of the Voices and Choices for Children Steering Committee, and also a member of the Community Solutions Advisory Council. I'm sharing strong support for SF 402 because I believe community solutions are a strategy that addresses and amplifies the innovative solutions that leverage community assets, cultural relevancy, and centers those most impacted by inequality. Communities do have the competencies and solutions that build on their local and cultural strengths, but are too often lacking the resources to implement them. The Community Solutions Grant Program is a strategy by which we can begin to address the disparities in resources to specific communities. It leverages the assets in the communities to address their problems, and I believe early childhood is the most practical place to close early educational disparities and inequalities before they become larger gaps and leave Minnesota with lower educational attainment rates and workforce shortages. Investing in healthier children and families earlier will create stronger communities in and across Minnesota. As a member of the Community Solutions Advisory Council, I have followed and supported the journey of our original grantees from 2019, whom shared many stories of success and resiliency. Some grantees becoming essential workers during the implementation of their community solution grants and during the beginning of the COVID-19 pandemic. Some grantees turning into heroes for the working families of young children in Minnesota who are collectively upholding our economy. Early childhood education, health, and workforce is an essential part of our society that we can no longer ignore and is due for a greater collective investment. I strongly encourage you to support SF 402. Sustained funding over a time will allow communities the opportunity to refine their solutions, extend their reach, and ultimately set up this generation of children for success. Thank you.
Thank you very much for your testimony. Now I have Fabiola Estrada. Please state your name for the record and begin your testimony. Okay. Welcome to the committee.
Thank you. Good morning, Ms. Chair and members of the committee. My name is Fabiola Martinez de Estrada, and I am the co-founder and subdirector of la Red Latina de Educación Temprana de MINCH, the network for early childhood education in Spanish. We received the Community Solutions Fund grant in 2020. La Red is a group of Latino leaders that are making healthy change that benefit children and members of the Latino community living in Richfield, Bloomington, and across Minnesota. We develop community-driven solutions to support healthy child development and early learning opportunities for children whose families chose or need child care for family, friends, and members or neighbors. We do this by providing cultural early childhood trainings, capacity, and leadership developed for Latina child care providers to deliver the highest quality child care possible and support school readiness. Our work is also change the lives of the FFM providers by changing the understanding of the role from just babysitting to knowing that we work and they do this important for the children in the future and our entire community. We have worked to support other families, friends, and neighbor networks across the state to help building the capacity and leading at the national level supporting FFM networks. The Community Solutions Grant Program has supported us to provide monthly trainings for family, friends, and neighbors, develop and our curriculum to provide free summer soccer activities for young children to support our family through the COVID. This grant program is different for other state grants we have received before. We like the state is acting as a partner with us and learning from us. The advisory community that sees our work, and it's really interesting to hear that we have to say in supporting what the community needs. Others funding for the state should learn from our community solutions found to better support for our communities. However, this grant program is time limited and have been able to fully fund for all the work that we need across to our communities. We need ongoing funding to support communities to lead on the work that they know will impact the health and build for the children. Please support the Senate File 402 because it will find solutions we know works for families and plan to represent our family, friends, and network. I'm happy to respond any questions you have about the FFM providers or LARED. Thank you.
Thank you very much for your testimony. I'm really happy to be able to know about LARED over my years in the Senate in my district, and it's really been great to see the work that's been going on. And I believe, Senator Kunesh, you have one more testifier.
Hopefully you have Mikey Brown online.
That's right, on Zoom. So, Ms. Brown, if you can introduce yourself and begin your testimony.
Hello, Chair Wickland and members of the committee. My name is Mikey Brown. I'm an Indigenous parent leader from the White Earth Reservation. I have one toddler, 2 teenage siblings, and 2 teenage stepdaughters that I'm taking care of. I have been a part of the Indigenous Parent Leadership Initiative for about 2.5 months. I feel honored to be part of an amazing program. This initiative has made a significant impact on my life already, not only as a parent, but as a community member. I have been able to step into my power and gain the perfect knowledge to become a better parent, leader in my type of community. I am currently part of the 2nd cohort. We are about halfway through this session, and so far we have completed an all-day retreat and 9 weekly class sessions. Together we have developed a safe place full of love and a community of like-minded people who are ready to assist in creating change in our communities. We all genuinely care about our communities on the White Earth Reservation. We have built a sturdy foundation of communication skills. We have talked about so many tough topics such as racism, trauma, mental health, grieving, child neglect and abuse, and how this affects the little ones, plus so much more. We have gone into discussion about what resources we have available on the reservation and what resources we need. All of us participants have been working on community projects that we each will be implementing into our communities in hopes to better them. Imagine each of us branching out to initiate a better part of the world. Little by little and with teamwork, this will create a ripple effect and change the community for the better. Big time. Starting with picking up our communities and getting our reservations to reach its highest potential. This initiative has changed many lives by educating parents. I hope this continues for many generations. I have been inspired and thought of many ways to help. Community Solutions aims towards the roots of the issues, and continued support of this program will help prevent these issues existing for our future and save money over time. I have been discovering my greater purpose and reaching for ways to put my plans into action to assist with creating better role models. Together we can better our future generations one step at a time.
Thank you very much for your testimony. Senator Kunesh, do you have other thoughts you'd like to share before we go to questions?
Just that it's really heartening to hear the positive work that's come out of this pilot grant, and really hope that we're going to be able to continue to really work with the community, because we know how important it is that the community is involved in the well-being of our children, no matter where they are here in Minnesota.
Thank you. Members, do you have any questions for Senator Kunesh or the testifiers? Senator Abler?
Who's first? Who's first? Anyway, thank you, and thank you, Senator Kunesh. And I actually appreciate your bill. The whole discussion of equity has been a long-standing discussion. And I actually did read some of the materials that you provided, which actually makes me kind of sad when I see how it's been going. One thing I just want to, as I read the thing from Voices and Choices, there's a definition of success that I was actually happy to see that there's some way to know when we've accomplished the goal. And it says racial equity is a condition that would be achieved if one's racial identity no longer predicted in a statistical sense how one fares in society. I think that, I don't know if that's your definition, but it's nice to actually have some place to know where we're trying to get to, and then when we've actually succeeded. And so I'm all for that. I was really disturbed when I read in the report from this this group here that from the whatever this Community Solutions Fund for report, and it must have disturbed you as well. It said grant applications submitted by leaders of color and indigenous leaders are less likely to be funded than those submitted by white leaders, and that's really disturbing. We already have a ton of programs that we've been trying to do to accomplish the very thing that you're setting out to do again. And I'm not going to ask the department to come up here, but I think it's appalling. This is not any Republican versus Democrat thing. This is a matter of the agencies of the state, which have been populated by both parties, more recently by the DFL. But they're not being fair, and there must be a lot of reasons for that, and it kind of creates the need for a group like yours to say, no, you better approve these. But there's an intrinsic thing in the department, particularly the Department of Health, where these different grants are going, where they're not doing that. And I had the opportunity to meet Commissioner Cunningham, and I think that I'm not even sure if she knows this is one of the things she needs to grapple with in the very department that she's been charged to watch, that they're not sending money out for health disparities, equity proposals, different health impacts. Because I would appreciate if the department could get me, not today, but a list of all the different monies we have put in to the grants system, but particularly grants, and like just what the list of those is. And it's got to amount to hundreds of millions of dollars. And that this very much concerns me. And so just the one thing is I'm happy that you're talking about dualism midwives. I think those are amazing. That's on the same page. But in your bill, Senator Kunesh, just wanted to caution you what you're asking for. And actually, I think given the current commissioner, you're probably not as great a risk because she's going to focus on equity matters. But it's on page 3, line 3.4. This council, line 3.3. You're going to set up the whole council, and you can put in that who you like. It's kind of limited. You might just want a little broader representation of the whole state in there, not just groups like that. But it's your group you're setting up. But they're going to advise the commissioner on proposals in a department that already isn't giving out grants. And so I don't know if the word advise is strong enough for what you want. I would suggest that maybe this group take over the guidance of the efforts to deal with equity and success. And rather than advise, there's a different word than just make her do it. But if you want this to work, there's a bunch of money that's going the wrong place, obviously not accomplishing the goals you want. And $50 million a year is a very ambitious number, $200 million in a biennium. If you get that money, I want to become close to you so I can do other things with money. But but there's that much money sitting in the till right now. And so then on line 310, you're going to advise the commissioner on accountability processes and advise the commissioner on line 312 of ongoing oversight. And then line 3.14, which is just a really vague sentence, support the commissioner on other racial equity grant efforts, whatever that that's not really even a meaningful sentence. But I suggest, and then something I like a lot on line 4.14 is the advisory council may recommend additional strategic considerations. The governor just recently set up a behavioral health, substance abuse, kind of a cabinet thing, where they're actually are going to be, they have stakeholders and they're supposed to feed back into the behavioral health department, which has had a hard time kind of being effective at the human services side. We spent the whole last session talking about that, trying to spin it off so it could actually work. And I think in a similar way, if you really want to make it different, make it different. And I think that you will see some success, and you know, the grants aren't going to go out till a year from now, and maybe you could speed that up even with this group. But I think since I've been here, we've been trying to solve health disparities with any way that we can think of. Here, let's spend $10 million on that. Let's work on diabetes. Let's work on low birth weight. Let's work on premature. Let's work on birth mortalities. And we have pretty much failed. We, as a bipartisan, bicameral, you know, people representing urban, rural, suburban, all races who have been here trying to fix this. And we have almost nothing to show for it. And so I'm just going to suggest to you use this as a launching pad to leverage government, not as a separate agency, but as a really loud voice to make a difference. And I wouldn't have said that if I wouldn't have said in this report that they're not giving you the grants. The very agencies that we think are in charge, actually, you know, frankly, leaning a little left, that they should have noticed that, and because it's intolerable, and you and I have shared that. And this is not a matter of who's more interested in helping somebody who has a need. This is a matter of actually getting about it. And if it takes $50 million a year and we can actually get to achieve the goal that you set up to where you can't tell the difference based upon, you know, your skin color and where you live and all that, we will have really done something under your watch with your initiative. And so that's meant to be helpful to this project. And I'm willing to support you in writing language, to even toughen this up to make it do what you want it to do and push on the departments. I don't think the departments go out of their way to really do a job that's not right. But the bureaucracies just get certain ways, and then you have scoring, and maybe some groups don't have good grant writers, and some people that are really mediocre with their program have great grant writers, and they take all the money and put it into something that does no good. But that's also a disparity that is being just continued by the system that we have. But I wish you well, and I hope you see that as a friendly set of comments. Thank you.
Senator Kunesh.
Thank you for all your work that you've done in the past to address the disparities. I do think the departments have a finer awareness of some of the grantees and the lack of granting to you know, the unevenness of that. I know there are efforts that are being made to not only assist with grant writing, but to have those voices, such as when it says advise the commissioner on ongoing oversight and support of implementation of grants and grantees, that we're bringing the community in and the people that really understand the grant and the communities. So I personally have seen a stronger effort and a more concerted effort in a lot of different areas when it comes to looking at those grant approvals, but also the assistance, like you said. If you are an organization that doesn't have a lot of money and can't afford a grant writer, that there are ways to assist in making sure that those entities have that kind of resource and assistance. So thanks very much.
Madam Chair.
Senator Abler.
And just want to appreciate the discussion, and I truly appreciate the effort, and it's just not acceptable where we are in some of these things. You went from $20 to $50 million just in a nanosecond, and you will discover, and you already know this, when the good chair has a budget that she's going to have to allocate somehow. That it's a number. I don't know if you can even, it probably takes more FTEs even than the 12 that this bill would require. But what I'm really suggesting is what you can rejigger in the existing programming then what, if that would be spent correctly, how much would you really need? And I think that case could be made just without changing your number, but I think that number, 50 is a little, I mean, it's a big number. Maybe, so thanks.
Senator Kunesh?
Well, thank you for that segue, because I do have to correct my A2 amendment. I used the wrong numbers in there. So at this time, Madam Chair, I would like to ask that the amendment be reconsidered and make additional changes to, and then adopt that amendment once again. So the amendment to the A2 amendment, and this would be an oral amendment, I'm assuming, on page 1, line 5, delete $50 million.
Senator Kunesh, I'm just going to interrupt you first. Can
Sure.
I make, I'd like to make the motion to reconsider the amendment and vote on that, and then we'll have the amendment, we can introduce the amendment and then make oral amendment to that.
Okay.
And vote on that.
Thank you.
So first, members, I'd like to make a motion to reconsider the A2 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? Okay, the amendment has been reconsidered. And now we have the A2 amendment before us, and now can you state your oral amendment to the amendment?
Yes. So page 1, line 5, delete 50,000 and insert 25,000, million, excuse me. Delete 50 million and insert 25 million. And then on page 1, line 6, delete 50 million and insert 25 million.
Madam Chair,
Senator Abler?
I'll move that.
Okay, thank you. So members, are you clear on the oral amendment to the A2 amendment as moved by Senator Abler? Seeing no questions, all those in favor of the oral amendment, please signify by saying aye. Aye. Any opposed? The oral amendment is adopted, and now we're back on the A2 amendment. Senator Kupek, can you move the A2 amendment as amended? Thank you. Members, the A2 amendment as amended is before us. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Thank you.
Thank you.
Now, members, are there additional questions or comments? Senator Etke, did you have a question? Okay. Any other members? I just wanted to see, or just state, I guess, raise up, there's one handout in here that talks about family, friends, and neighbor childcare providers, and specifically about LARED and the organization, and I just wanted to say that in terms of the work that we're doing on childcare, I really am glad that the Community Solutions grant program has been able to include the work and fund work that LARED is doing in this area of family, friend, and neighbor childcare. It's a really important type of care that you can see on this, excuse me, on this handout, that nearly 40% of children aged 2 and younger, are estimated to be in family, friend, and neighbor care. It's really an important sector of our early childhood system, and in the past, it's been very challenging for groups and providers to get support for the work that they're doing, and the work that LARED has been doing has started, many years before this pilot program. This is something that's been established, and I wondered, Fabiola Estrada, if you could talk a little bit more what you think the key difference, has been with this Community Solutions grant that might have helped you more than past efforts that we've had in this area.
We start a couple of years ago, like more than 10 years. We no grants, just by volunteer. And I was a volunteer. Like in 2002, I started working with Ruth, who is the director, and you meet her yesterday. She said that I have 6 children, and she said, "Hey, come here. I have programs." She was working in the church, and she saw me, and I was pregnant at the time. And she said, "I have so many. I offer some programs for the church to the children to do in the summertime, and if you would like to bring your children, they are welcome. And we teach CPR for kids and other activities for them." And when I started getting involved in that program she offers, I saw that it wasn't people, only her, and I think another lady, but they don't have money to provide those resources for the children. And I started being the volunteer. I was the teacher for dancing because I was a really good dancer in my country for those dances for every state. They had different style of dance. And I was teaching the children how to dance for our country. And later I was the teacher of art because I know how to create a lot of art. And we had the children, she asked it to somebody to have a little space in the summertime in the park, and they provide the little space of the park for the children. We had like 15 children, and only was she and me. Mm-hmm. And we take care of the children for 9 o'clock to 3 p.m., and we had different age. Not only we don't accept babies because they will be really hard work for us. We accept like 5 to up. And the big ones, for example, 14 and 15, they take care of they helping to us to create. We play soccer and we create a lot of stuff for them. And how we start. And later we see that we need to have money to provide more and more. And we were like step by step doing this until we find Blue Cross Blue Shields, who give you the opportunity in Bloomington Health, Department of Health. They start believing and trusting our job because this is really important. It wasn't only for the children, it's for the families who take care of them. And they are, sometimes those people, they don't have the high education, but they have the knowledge, and it's how we climb. And we had the opportunity to get those grants and start little by little. And we extend our program, and now the program is getting big. We have 3,000 members. Each class we provide. Now we are in Shakopee and Richfield. We have 2 places because some ladies, they don't have transport to come to Richfield in the morning, Saturdays. We need to go. We start working now Sundays in the afternoon, 5 o'clock to 7 or 8 o'clock. Keep going with the classes. We offer CPR, baby, checking baby, suits, healthy food, and the summer, with the pandemic, we have soccer for the children. We have hockey, and we changed our pace. We working with another another program. They offer food to us, and we start providing food twice a month during the pandemic for almost 2.5 years. We stopped this summer in August because the school is getting bigger too, because partnership is providing a lot of classes. They grew up, and they started building more rooms for those children, and we stopped because they use all the parking to bring all the stuff they needed for building those rooms. Yeah, and we stopped. And now we don't know if we continue to do that because we see that people need these products and resources. That's why we keeping going to be stronger. And doesn't matter, we say, doesn't matter if we don't have too much money. We, Ruth and I say we still working. I don't know how we do, but we still working for the community because we start like that. Thank you.
Thank you very much. And one of the things I appreciate is that they have a way to connect families, not only to health services, but also to the school and schools, how the schools work in our communities. Just is a great way to strengthen the whole community by these
Yeah.
programs. So
We
thank you.
need to have the community, because I know we have some friend, those FFNs, they have education, high education in their own countries, but we coming here is like you are no value, but they have the knowledge, and that's why for example, I take those classes because I am training too. I took those classes in English, and later I go to my house and I like to write too much by my hand. I translate those classes in Spanish, and I culturize because our language is Spanish, but sometimes the words are not the same. You know, we need to culturize all these things for those people, and they can have the knowledge to take care of the children. That's why we offer a lot of classes.
Great. Thank you. Thank you very much. Members, any other questions? Senator Hoffman?
I do on the overall bill, Madam Chair, so whenever you want to get to that, is that, where are we at that now, or is that?
Yes, that's where we're at.
So I'm going to get a little weedy. Thank you for bringing this forward. I'm going to give some suggestions that I think the system, as you're looking at this, this is a wonderful bill, and I'm glad it's addressing. There are 11 priorities that the Department of Health has established under the Maternal Child Health Bureau Division. And if Lisa Timian is here, maybe she could be the one to just validate that this is what's going to happen. So my question is really toward the system. On the 11 priorities, one of those is the American Indian Family Health perspective. We have to tell the federal government this is what we're doing. What you're doing here fits within the plan that Minnesota has to put together every year and to send to the Maternal Child Health Bureau, which is part of Health Resources Service Administration. The other one is there's a comprehensive family health provision in there too, within those 11 priorities. I'm not seeing any of that stuff, although it's probably assumed when you do make reference to the commissioner shall, right? But is my historical knowledge of, if we don't really point to where within the structure already things exist, it's going to be one of those pieces where, you ever been in your kitchen and you open up your cabinet and you have the beans over here and the corn over here, and then there's a bean over here by the corn, and you really should align the beans with the beans and the corn with the corn, right? So if you can visually imagine that, typical Minnesota, we put these bills together and then we don't align the beans up with the beans and the corn with the corn. I stole that from a certain analyst, and I'm going to keep using it 10 years ago. So my suggestion to you as you move this forward is, A, that there's better information that's highlighted in the bill regarding how it's going to interact with the Title V program that the state of Minnesota puts together, which has to be comprehensive. And then the other one that comes in, when you're looking at the early childhood, there are two things that are missing deliberately, not deliberately, they're missing in this bill that I would like to see put in here. Part C is your early intervention services program that's established. Do you want me to give you the history on that? I won't, but it was established in 1986, but it told states you have to be comprehensive, coordinated, and collaborative, right? Under Part C, they look at not at-risk factors, but at risk for later delay, but it fits in there. Where is that language in here in partnership? And then Part C, because Minnesota is a birth mandate state, guess who has jurisdiction over Part C in the state of Minnesota? That would be the Department of Education. I'm not seeing that in here. And the third one, as you look at establishing this group, you make reference to the commissioner in consultation and the other commissioner. I think it needs to be really clear in there, because in the Department of Health, they have to specifically look at perinatal and prenatal, and you mentioned prenatal in this bill, but again, there's no direct line to those health indicators that the department has to establish and does establish. So I think for lining the beans up with the beans and the corn with the corn in your kitchen cabinet, I strongly advise that those other entities get in this. Because the other thing it does, when you start to tap into Part C, of our 11 tribes, four tribes get early intervention services money, right, that come from the Bureau of Indian Affairs through the National Bureau of Indian Affairs through the Department of Education, then gets to the tribal councils, right? And there's one that absolutely does it well. Red Lake has this early childhood building, and I was so blown away years ago when I saw how they integrated early childhood, family ed, early childhood special ed, early Head Start, all these school ready, everything was under this beautiful building, and it made sense because that's what they did. And it was that money, part of that money was established from that, and that money comes from Part C of IDEA, just if anybody wants to know. I don't want to sound wonkish on this, but it kind of is my bailiwick, and so I think this is really a wonderful piece of legislation. I think this is a time for us to really enhance our agencies, to look at the collaboration, coordination, and comprehensive work that they're supposed to be doing in this field already, right? And so I don't know if Ms. Timian wants to respond on the whole thing on Title V public health, or if that's just something you want to take back and work on. But regardless, I think I want to help this, enhance this really wonderful. And because you even mentioned, the tribal nations and tribal organizations, they're doing some great stuff in there. It's now let's coordinate, where. And I highlight Red Lake because of the fact that early childhood center. And I forget offhand the other three that get that specific federal IDEA dollars specifically for early intervention. So does that make sense to you, Senator?
Senator Kunesh.
Thank you, Madam Chair. Yes, Senator Hoffman, thank you for your depth of knowledge on these issues, and maybe what I will do is sit down with you and we can expand on this a little bit more. Appreciate it.
Sure, Madam Chair.
Senator Hoffman.
I'd love to give you a whole history of how these came into being and where they're at.
Maybe just the cliff.
Senator Abler's already
Maybe
saying
just
no.
the cliff notes.
Thank you. Thank you, Senator Hoffman. Any other questions or comments? I just wanted to add on a little bit to what Senator Hoffman said. I think this program I have found encouraging because of the work or the specific nature of trying to address the cross-sector systems and coordinating systems. Not only because we can make better use of our resources, but more importantly, we can make sure that families have a much easier and more straightforward time, navigating the system and navigating the different programs that we have available and making sure that that all kids have access to them. So I really appreciate your bringing the bill forward, and I look forward to seeing it progress. And what we're going to do with this bill is it needs to go to State and Local Government and Veterans Committee. And so we will have it go there. We will have to determine how to get it back, after that. So we have to talk more about the path back to the Budget Committee. But for right now, for today, we are going to have it travel to the State and Local Government Committee because of the Advisory Council. So, Senator Abler.
I can make the motion that it go there.
Senator Kupek is prepared.
Oh, is that right? Well,
but
then let him, fine.
since-
I will yield to the good senator.
All right.
Paper, scissors.
Thank you. Yes. Senator Kush, did you have any other final comments that you want?
No, but I do appreciate the recognition of what a stellar program this is. You can hear that this is really a grassroots effort, started within the community by community members. Often, as we heard, they were not charging families or they weren't getting paid for it, and it's evolved into a program that I think is an exemplar, and just really proud and happy to be able to carry this bill and look forward to enhancing it and enforcing it in a way that's going to make our communities even better.
Thank you. Senator Kupek.
Thank you, Madam Chair. So I move Senate File 402 as amended be recommended to pass and be referred to the State and Local Government and Veterans Committee.
Thank you. And on Senator Kupek's motion, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does pass. Senate File 402 is, as amended, is recommended to pass and is re-referred to the Committee on State and Local Government and Veterans.
Thank you.
Thank you very much for bringing this forward to us today.
Thanks.
And now we are going to move to an informational presentation by the Department of Health. I asked the department to come forward with this presentation on the all-payer claims database because we will be hearing, at some future hearing date, we will be hearing at least one or two bills that have a connection or have make use of the all-payer claims database. And it is a fairly technical it's a resource we have access to in Minnesota. We have the ability to learn from this resource, and I wanted to make sure committee members kind of had background on the overview of it. So thank you, Mr. Gildemeister, for coming to the committee today to present that overview. And if you can state your name for the record and begin your presentation.
Good morning, Madam Chair, members of the committee. For the record, my name is Stefan Gildemeister. I direct the Health Economics Program in the Minnesota Department of Health, and I'm the state health economist. And thank you for having me this morning. You almost took my introduction, Madam Chair, but the Minnesota All-Payer Claims Database is essentially a data asset the legislature created that is a powerful tool for providing information in key policy areas such as healthcare spending, how much we spend on what services we spend healthcare, to what extent they're affordable, in other words, what individuals pay out of pocket, how efficient the system works, how much waste there is in the system, what there is to know about healthcare quality, disease epidemiology. We look a lot with these data at the healthcare market and also inform public health. So really an important asset that Minnesota has developed in early 2009 as a bipartisan initiative. Minnesota is one of 17 states that operates an all-payer claims database and one of the early ones. So what is the Minnesota APCD? Is it a tool, a toy for researchers? No, not really. The APCDs are large-scale data systems that are really a byproduct of the healthcare payment system, where we track what services were delivered, at what cost, and who's responsible for paying for them. So it's as I say, it's a byproduct of the interaction between providers and payers. Generally, it includes information on enrollment, who has insurance coverage. It includes medical and prescription drug claims, and then transaction prices for services provided. It is just by its nature a geographically rich data source with detail for insured Minnesotans on diagnosed condition, what treatments were provided, and who the servicing providers are. It includes data for individuals on Medicare and state public programs, and also individuals with commercial insurance, which of course 60% of people in the states state hold. The commercial data has gotten a little thin starting in 2016 because the Supreme Court ruled that states cannot compel employers to submit these data, but nevertheless, there is really powerful and strong information around individual, small group, and group coverage in these data. Sort of collectively, there are 11 years of data available for about 5 million unique covered lives in the state and about 2 billion claims. The data is de-identified, and what that means essentially is that typical identifying information is not part of this data. That's both an asset and also, to an extent, a weakness of the data. Not all states do it the way Minnesota does, but things like patient name, date of birth, social security number, patient address, detail on income, or in detail from electronic medical records, none of that information is in the data. It's a strength because it lowers the risk of these health data. It's a weakness because it creates some data integrity issues that you can't resolve if you can't always link up individuals. How are these data available? There are essentially two ways. The legislature, in establishing this initiative, limited access to the data to the Department of Health for use in analyzing variation in healthcare cost, quality, utilization, and illness burden, including looking geographically at the distribution of these things. So we make the data available through our research findings in briefs, reports, and data short takes. Secondly, we have established summary public use files and in an interactive data dashboard that sort of is indicated by the graphic on the right-hand side, and I'm happy to show some of this to you. Strength and limitations, I've really talked about the strength a little bit. Some of the limitations is, by the nature of the program limited to MDH, there is limited expertise and staff who can sort of create a return on investment of these data. We don't typically have clinical expertise on our team or actuarial science represented, so we can only reach so far with the use of the data. Currently, and this is more a feature of the insurance claims system, there are no data on race, ethnicity. We don't collect dental claims data, and as the dental advocates tell us, the mouth is part of the body. So clearly a weakness. Clinical data is missing. That means for some analytics, you really lack detail on lab outcomes, progression of disease, things like that. And there are some constraints to healthcare market transparency in that the data currently is not permitted to identify provider organizations. So I'll show you in a second some work on hospital data. We can't identify them. We just label them as hospital A, B, and C. And when we show these data to employers, they're saying, well, how is this helpful to me? I need to know how the hospitals in my network relate, how their prices relate to other prices in the market. So a concern with the effectiveness or the extent to which these data are fully effective. There are some limits, again, by the nature of how the data were organized. We don't have data on uninsured Minnesotans. There are some federal programs that are also not represented in these data. Something we keep working on, but these gaps exist. And then I mentioned the gap related to the Supreme Court decision on ERISA preemption. And this is one example, most recent publication, where we looked at healthcare spending, prices, and use in Minnesota between the 5 years, 2016 to 2021. We're just updating it right now to 2020 to 2021, and essentially we're looking at the drivers of healthcare spending, sort of between utilization and prices, what drives healthcare spending. And you all know the notion that it's the price is stupid, and it really is, and it has been even when utilization fell or particularly when utilization fell in 2020 during the COVID pandemic. Prices continued to rise. So this provides insight about trends in the market, spending, volume, and drivers. I mentioned this a second ago. We looked at common hospital procedures and analyzed pattern of hospital prices within facilities and across facilities. And again, we find something that I think many of us know, but it's still really useful to see in hard evidence that there's huge variation in prices across the state, but even within hospitals. So essentially, there is not one price for delivery of a appendectomy, but rather as many as their contracts, and market power drives the prices that are being charged. So the market, the healthcare market, which I think we organize healthcare around in Minnesota, is not really working effectively. Transparency is missing. Many of you are aware that the health department, in partnership with Commerce and the Human Service Department, is looking at a study of telehealth, particularly on impact on healthcare access, spending, and disparities and utilization. This is earlier work where we sort of began to track trends in telehealth in Minnesota, and these data help the state inform the legislature on policy decisions around the telehealth space. The report is imminent, I should say. Our colleagues in the public health section of the agency have looked at hypertension prevalence and medication adherence, and have worked really closely based on these data with pharmacists to increase medication adherence. We've looked at opioid prescribing in Minnesota, identifying patterns of addiction, overprescribing, and estimated the volume of newly addicted individuals based on past patterns. And then there are these public use files that I mentioned earlier that we generate. How about I'll show it to you if you want to take the time on it. But essentially, these are summary data at the member services utilization level, looking at provider specialty and prescription drug, where we look over time and where we analyze data for different services. The purpose of the dashboard really is to make these data accessible to individuals who are not SaaS programmers, who have a variety of analytic and technical skills. These data make this information accessible on healthcare use, healthcare cost, distribution in the state. And then just wanted to close with giving you an overview of the kind of work that we're doing with these data currently. There are 19 active studies at the health department using the Minnesota APCD, and they spread, again, the topic areas across the topic areas that I mentioned early on. I won't read this all to you. I'm happy to share this slide deck, or I think it's available. But maybe to pick up on a couple of things that have not already mentioned. So in the legislative space, we use the data to inform the mandates estimates that the Commerce Department and the Health Department work on together. So we look to assess what cost mandates might have to insurance benefits and how it affects premiums. I mentioned the work on cost drivers, which I showed you a slide on, but we're also looking quite actively on patterns of out-of-pocket spending across payers for prescription drugs and medical services, but also for specific diseases, to help you inform decisions around bills in this space. The individual and small group market is an active policy area for the legislature. So we're looking at trends in benefits and enrollment and premiums. How are people buying coverage? What benefits do they purchase? And how is the choice between the metal level and ultimately individual spending? How does that play out do individuals end up with a kind of health plan that is affordable and generates the health insurance and health access that they're looking for. In the public health space, there's work ongoing related to antibiotic use, medication adherence, I've mentioned that, dementia prevalence, and cardiac rehabilitation. We're beginning a number of areas of work concerning sickle cell disease, and your testifiers in the first bill, we've talked to you about how to use these data effectively to support rare diseases analysis and transparency. We're looking at mental health diagnosis and utilization, fetal alcohol syndrome disorder, and neonatal abstinence patterns. And I could go on, but I think these are the things that keep us busy right now. This is my last slide, Madam Chair, and I'm happy to take questions.
Thank you. Members, do any members have questions? Senator Abler.
Well, thanks. Nice to see you again. You've spent a lot of time, and I've been always amazed at how you remember all this stuff. Anyway, so of the governor's proposals this year in the health department or any budget, are some of those proposals informed by this content? Did you already say that, or did I miss it? Or just curious what the output is then.
Mr. Gildemeister.
Madam Chair, Senator Abler, a really good question, and I haven't thought about it quite that way, but I'll try to work on an answer as I think. So there are a number of proposals that explicitly look to address certain weaknesses or limitations in the data. So Commissioner Cunningham has really encouraged us, challenged us, pushed us to collect race ethnicity data as part of this database because of all of the reasons that motivate that decision. It's an uphill challenge because these data don't exist typically in insurance arrangements, but we have to start somewhere. So that's one. Dental claims is the second one. The governor has a budget initiative to strengthen affordability by establishing spending targets, sort of recognizing that healthcare spending moves faster than inflation, and by doing so, it takes out resources from the community and adds it, frankly, into the healthcare system. And that initiative is driven by this ongoing analysis of spending trends, of analysis of waste in the healthcare system, of which we think there's somewhere around 20–25% of total spending. Other areas where the governor's initiative or the budget proposals are informed by this work relate to certainly the public option. It is a function of how much we spend and how affordable healthcare is for individuals across the state in different rating regions and with different exposure of out-of-pocket payment. So those are the things that most quickly come to mind. I might phone a friend to see if I'm missing something obvious. Yeah, so the two initiatives that I mentioned that address some of the limitations are to strengthen the APCD, relate to dental claims and race ethnicity. I know there are bills that you will be hearing, and the chair mentioned that take the APCD farther yet, beyond what the governor's proposal was to look to open the data up to more use for a public benefit and to overcome the limitation on identifying provider organizations in the data. So that's my very long answer to your very precise question.
Senator Abler.
Thanks for calling my question precise. And I appreciate the answer. And, this has been, a subject of much discussion about privacy issues. And I respect privacy a lot, but this is all de-identified. And I don't know how you ever get ethnic data out of that. When we submit our claims, it doesn't say what, ethnicity is not one of the boxes on an insurance form that you can collect. But I just, it seems like there's like they've done a ton of research with, like, if you're 50 and what did you do, did it work? And there's just so much that could be gleaned from some of this and some of their methods that could help us actually figure out what those 25% of the things we're doing that just don't make any sense. So it was interesting to hear your answer. And since you brought up the idea of cost, personal contribution to your health care is a meaningful number. But on the expansion of Minnesota Care, I would also hope that you would notice that a $10,000 hospital cap might affect some hospitals who actually want to stay open in greater Minnesota, and that you can't pay nurses scale on Minnesota Care wages. And so I hope that that would come out of your department as well. Thanks, Madam Chair.
Thank you. Members, any other questions? Senator Kupik?
Yeah, thank you. Yeah, and I think addressing some of these limitations, a lot of this too goes to things that Senator Abler had said before about, taking care of some of the disparities that we have in healthcare across the state. And as we move forward in making those decisions, Madam Chair, as we're spending that money, I think having more data on that disparity and addressing these will help us moving forward on that. I am also fascinated by the maps, because I'm also a map guy, besides a data guy. The interesting disparities from south to north across the state of Minnesota. It's that kind of, it's not even almost rural urban. It's almost just south to north. It could be a weather map that I'm back looking at, temperature or something. But it's thank you. But it's just that's an interesting dive into the data here. So I yes, thanks. So I appreciate if you'd like to address that. Yeah,
Madam Chair.
Mr. Gildemeister.
Madam Chair, Senator, I can hook you up with tons of maps. And, we looked at geographic information for children's health, for chronic disease patterns, and of course many of those are affected by the age distribution and other factors, so you want to adjust those, but yes, geography and showing variation visually has been a really powerful tool for even to us to take pause and ask ourselves, well, what drives that? So thank you for recognizing that. And then, Madam Chair, if I may follow up to Senator Abler's comment, the issue with the box and race ethnicity is really an important one. But as I started to say, we have to start somewhere, and this is not as simple as saying to the health plans, submit this data, because they might not have it. So really, if we are serious in holding or in having data that is specific at the race ethnicity level, we have to work with employers to help them understand that collecting this data is legal and serves a purpose. We have to work with enrollees, people, residents, and make them understand collection of these data serves the policy purpose and improving healthcare rather than is a way to foster discrimination. And then ultimately, we sort of have to use information that emerges effectively to demonstrate that collecting these data served a purpose. So it's not just now we have the data, now we hold it, now we're happy, and we can do a range of analyses, but rather we have to bring it back to the community and say, and this is how your data comes to play, whether that's about access to novel prescription drugs or access to life-saving surgeries or chronic conditions.
Thank you. Senator Kupik, any more? Okay. Anyone else have questions? Senator Abler.
Well, thanks, Madam Chair, and I just, this is a sideways compliment. So to try to change the HCFA form, to put a box on there, makes every process at your department look extremely effective and efficient and quick. So it's, I can't imagine how that would go, but I appreciate the thoughts and good luck to you.
Thank you. Mr. Gildem.
Madam Chair, we do have a really awesome team, and we work with vendors who we hold accountable, so the plan is to continue that. But thank you.
Any other questions, members? No? I just wanted to ask one thing about, in terms of when you talked about utilization and, for example, settings, can you just talk a little bit more about your limitations in terms of how granular or how specific that can be for us in terms of you can drill down to provider type, but not beyond that? Maybe just describe a little bit more about the limitations as you get into like provider data and like insurance provider or carrier data.
Absolutely, Madam Chair. So the data is really incredibly granular, and I want to make the distinction between what's in the data and what we can publicly make available currently. What's in the data is essentially detail on the servicing and billing provider. So the data tells an insurer and therefore tells analysts who has delivered the service and at which site. So there is an NPI that identifies the provider and the location. We through this NPI typically, claims data is never that easy, but through the NPI typically we understand whether it was a doctor or a nurse practitioner, and we know again through the NPI what their specialty is. So it's very detailed information: clinic site, hospital location. The healthcare system is complex, and I think maybe this is another opportunity to answer Senator Abler's question about the governor's budget proposal. One initiative is to make investment in a provider directory that help us understand whether a provider organization is truly part of a hospital versus an independent entity. So rolling up providers to medical systems is kind of complex because of how they're coded. Takes a lot of work. So a provider directory would help with that. But yes, to answer your question once more, the data is really incredibly granular to distinguish between the prices, the servicing provider. So other states have used these data to look at the cost for delivering simple imaging services within a hospital setting, in an emergency room setting, or in a freestanding service environment. So those distinctions are possible and very powerful, and I think we just have to do more work in this area to understand incentives, efficiencies, waste, and as Senator Abler said with regard to the public options, it's a knobby problem. So it's not just by saying where can we drive healthcare so that it can be delivered at lowest cost. There are efficiencies in access as well, and there are also health system financing questions. But yes. That is why I get so excited about the APCD, because it really provides, exists as a very powerful tool to answer these important policy questions.
Okay, thank you. Members, anything else? I really appreciate your putting this together so that we have kind of a baseline, and members may think of other specific areas that they'd like to explore, and hope that it gives people a way to do that. So thank you for putting that together, and we may need to, as we go through the bills that are specifically have that component involved, but this really helps us get started on that analysis. So thank you.
Thank you, Madam Chair, and happy to come back again.
Great. Members, seeing no other bills or work before us, our meeting is adjourned.